All right, so I am going to start us off. First of all, I just want to thank everybody so much for coming and participating today on this very important issue of seniors and what we've learned through experiencing COVID-19. And I think, for myself, as the former senior spokesperson for the NDP, a lot of these things I knew about, but this exposed it in a totally new way. And I am just really happy to be here today with Laura Tamblyn Watts and Isobel Mackenzie to talk about these issues. So as you all know, I am Rachel Blaney and I'm the Member of Parliament for North Island-Powell River. Although I'm no longer the senior spokesperson, I'm focusing more on veterans and Indigenous issues right now. This is something that's very close to my heart, and I'm very grateful for the people who are here with me today who've worked hard with me on different issues. So today, what we're going to do is we're going to have these amazing guests talk about seniors issues and advocacy. We're going to encourage you to type any questions in the chat that you want. We will do our best to get as many as possible in. I do want to let everyone know that we got a lot of questions already from the riding, and I will be talking about some of those as well. This event is being recorded and it will be online afterwards so that you can share it with people. And we will also be taking an opportunity to circulate a questionnaire afterwards to constituents that will just inform us about what we want to send on to the Minister of Seniors and other relevant ministers in the government. If we have you have a question with us today and we don't get an opportunity to answer it, please let us know. You can call my office at 1-800-667-8404 or send us an email at rachel.blaney@parl.gc.ca, and we will get back to you as soon as possible. So what I'm going to do now is I'm going to introduce Laura Tamblyn Watts. I'm going to let her take an opportunity to chit chat with you guys a little bit about the important work that she's doing. And when she's done, I'm going to introduce Isobel Mackenzie and talk to you about her and then allow her to give a 10 or 15 minute presentation. And then after that, we will get to your questions. So first of all, I just want to introduce Laura Tamblyn Watts. I've been working with her for many years, and I'm really very happy that she's here with us today. She is the President and CEO of CanAge, Canada's National Seniors Advocacy Organization. She is an executive member of the Canadian Bar Association's National Elder Law section. She's a board member of the National Initiative for Care of the Elderly and a fellow of the Institute for Life Course and Aging and teaches at the University of Toronto, and she is joining us today from Nova Scotia. So Laura, it's over to you for 10 minutes, 10, 15 minutes. Thank you.
Very much, Rachel, and welcome to all of you today. I'm usually in BC or Toronto, but I'm also in Nova Scotia in a truly pan-Canadian style. I'll be back in BC in December, and I'm a BC girl, so it's lovely to be home, if you will, in this sort of Zoom setting. I also just really want to thank Rachel. Her work has been tireless. Her commitment has been true, and her leadership has been exactly what we have needed in the field of aging in Canada. And when she was formerly the seniors critic, she was somebody that we would be talking to a lot. She's now not formally the seniors critic, except we're still talking to her as much as ever in her many other hats that she's wearing. And I know that her passion and commitment to this area come both from her representation of you as constituents and more broadly as Canadians, but also from really profound lived experience. And I think that that does shape so much about how we look at these issues. So thanks so much, Rachel, and welcome all of you. Really happy also, I'm going to be active in the chat. You see that I'm already active in the chat. I'm also very pleased to introduce Diana Cable, who you'll see in the chat. She's my Director of Policy and Advocacy. Diana will also be sending links and these types of things that we can capture and make sure that also Rachel and her team have them so that it can be distributed afterwards along with our PowerPoint presentation. So in case you're trying to capture notes, you don't need to. We'll be making sure that you have all the information that you need. So I want to talk a little bit about kind of where we've been and where we are and where we need to get to in regards to, broader issues of older people. And I'm so also delighted to share the stage with my good friend, Isobel Mackenzie. As the Seniors Advocate of BC, Isobel has been at the forefront of these issues, both in our province of British Columbia, but also nationally and internationally. And I know that she's going to speak a bit to her report. I just want you to know that when I read her report, as it was being launched, I put my head down and cried. And it was not because she was capturing things that we didn't know. It's that she was capturing it so crisply, so cleanly, so poignantly, telling the stories of our families, friends, neighbors, and our own residents who are in long-term residential care. I may use the term long-term care. I know in BC we call it residential care, but it's sort of the more broad term. So if I use the terms long-term care or residential care, I mean them to mean the same thing. I'm talking about them just as interchangeable terms. So our organization is a national nonpartisan organization. We work at the intersection of community and individuals with government, not-for-profits, academic organizations, and where possible, also the private sector, to try to make positive change for all Canadians as we age. We have teams in BC and we have teams across the country as well. We're really trying to problem solve issues, and we know a lot of the issues that have plagued our response to COVID-19 are long-standing issues. And I don't know how many times I have been asked, am I shocked or surprised at what's happened, particularly during COVID-19, to our older citizens in Canada and also more specifically in British Columbia? And I've had to say, no, I'm not shocked. No, I'm not surprised. I'm horrified. I'm devastated. I'm upset. I'm committed to making better change happen. And I have a reason to be up at 3 a.m. But surprised and shocked, no. Because so many of the issues that we've seen are exacerbations of pre-existing challenges that we've had. And we know that seniors are very often a focus of conversation at governmental levels. And also the systemic issues are often conversations where hand-wringing is happening. And that is most specifically true when we think about our health and housing continuum. The good news is this: we actually know how to make it better. It's not a problem like COVID-19, where I myself am not an epidemiologist and I can't get test tubes out, and I don't know how to fix the problem of COVID-19 at a molecular or vaccination or treatment level. But I do know how to fix it across this country, because we've had decades of excellent work, excellent research, excellent reports, and there is really quite a broad consensus about how to improve things. Again, this is most specifically true around the issues that we're going to be more focusing a little bit later on. So our organization decided that the best thing that we could be doing during COVID-19, in that we were not ourselves the epidemiologists so desperately needed or frontline workers, was to actually do the heavy lift. So Canada has never actually had a strategy for aging. We are unique in the OECD, and not in a good way. And we actually don't have any excuse. We've known the population is aging. It's not a surprise to anybody. The headlines are fairly constant pre-COVID-19 about the issues associated with financial security, elder abuse, the worries about outliving money, the worries of bankrupting our own sort of social safety net. But there wasn't a place and a space. Efforts have been tried over the years to put things together, very often from a medical model or, a couple smart people in a room with a pen. And it's just not the way that we need to do things. So we did about 3 years of work in 5 months with a team of 20, working about 24 hours a day. And we want to offer to you this roadmap, and that's what it is. It's a roadmap to making Canada more age inclusive. It is essentially what it is that we need to do in Canada to respond to the needs of our aging population, to plan for how to do more and better. And it is really easily navigable. For those of you who are computer savvy, I really recommend that you go online, and I'll put the link in there as well. Diana can put it in more easily than I at this moment. It's canage.ca/voices. You can use that document by just clicking, and it will open up and expand very, very easy. But here's a summary of what really a national platform for aging looks like. And I'm hoping it's going to resonate with you. So our roadmap has 6 big compass points, which you see here. And then I'm going to go through the 40 issues at a high level, and I'll leave you or us to talk more specifically about the 135 very specific recommendations. And this is made so that communities, individuals, corporations, nonprofits, groups that are inspired, as well as policymakers, can activate around what needs to be done. It's synthesized, it's at your fingertips. It's nonpartisan. It is literally the reflection of the expertise across all sectors in Canada. So I'm just going to very high level go through what each of those is. Our violence and abuse prevention is our first area. And I don't need to tell many of you about the concerns. I've already seen from some folks in the chat that they're already concerned about issues about elder abuse and neglect. But what has been exacerbated during the time of COVID-19 is profound on abuse and neglect. So we raise issues, and again, online you can open it up and you'll see many different very specific recommendations around abuse and neglect prevention. In BC, we know that we have one of only 2 clinics to help low-income seniors. Seniors First BC is in Metro Vancouver. And we also have the Sail Line and BC Centre for Elder Abuse and Neglect's older materials are out there, but we actually have very little in terms of response. And we're about as good as it gets in this country, and that's not very good, frankly. We need more resources, we need more awareness. But let me just speak a little bit to what we've seen over the course of COVID-19. We've seen an increase of about 10 times the calls. Now, for those of you with an academic background, I'll say that this is evidence with a small e, not a capital E. And what I mean by that is it hasn't been run through rigorous academic evaluation. What I will say is this is what we are hearing on the ground from community responding organizations, that they're getting about 10 times the calls that they used to get. And that started very quickly. That started in the middle of March to the beginning of April that increase happened. What we're also starting to see is that the focus of increased abuse and neglect during COVID-19 has been more in the areas of reported financial abuse and physical abuse. And let's just sit with that for a minute. It means that older people who are in the community, about 92% of seniors are in the community, not in long-term care approximately across this country, are at home with their existing abuser, or new abusers have moved in with them. About 2/3 of all elder abuse and neglect is perpetrated by family members, friends, and those closest. And the other third is kind of a combination of new best friends, fraudsters, scam artists, and others. And actually, that's true for every area except financial, where because of the opportunity that COVID-19 has presented, we are now at about 50-50 for financial elder abuse between those closest and those that are strangers preying upon. And that's not because the amount of financial abuse has gone down, it's because the amount of stranger abuse has gone up. So the total numbers have spiked, and they have also evened out because of the predation that we have seen. We know from our prevalence studies that about 1 in 10 seniors will report elder abuse and neglect. We believe it's about 1 in 5 for other forms. And I challenge you to find anybody who hasn't at least had a touch point or experience about financial elder abuse. I've never met anyone that didn't get an email from a Nigerian prince or a phone call saying that the government is going to send the police after you if you haven't done X, Y, or Z. The reality is it's a huge and systemic issue. This federal government has given about $257 million to domestic violence since the start of COVID-19, which is fantastic because we know how important it is to respond to domestic abuse and intimate partner violence as a systemic issue. Do you want to know how much money they've invested in elder abuse? Zero. Not a dollar. There have been some programs that have supported social inclusion, which is very important. There have been some areas and attempts to raise awareness through things like free webinars. There's been social media. But if you are taking a systemic issue like abuse and saying we'll invest for children, we'll invest for youth, we'll invest for women and intimate partner violence victims, but somehow there's no money for elder abuse, it makes you think about what role ageism plays in valuing older lives. So this different landscape of COVID-19 is changing and impacting abuse and neglect, and only in the sense that we need to know more and respond better. Our O in our Voices national platform goes to optimal health and wellness. That's where you get your acute care, preventive care, and chronic care. And you see that we have indicated a wide variety. I'd love to come and talk to you about healthcare at some point because I know that that's an area that we could go all the way down in. But that's where we look at issues like wait times, need for increased rehabilitation medicine, and making sure that acute care is not the only kind of care that we get. Never before has infection prevention and disaster response been so important? And the I in Voices speaks to that. So we know that BC is significantly lagging behind. It's one of the worst in the country on vaccinations for adults. It's actually shocking how poor and outdated it is. One of the most effective ways that we can keep people healthy and well is by vaccinating. And yet, British Columbia has only recently, and with the support of federal funds, included the appropriate vaccine for older people, the high-dose flu. So if I'm going to get the flu vaccine, I get the regular one. If my mom, who's 83, gets it, she should get the high-dose one. Except the British Columbia government has not paid for that. And that is because we have devalued vaccines for years and years and years. Well, now I have to tell you, I think people have a good understanding about how important vaccinations are. But we don't have a vaccine for COVID-19 yet. I'm optimistic. But in the meantime, the best thing we can do is make sure that older people get the vaccines that are designed for them and have them covered. So one of the actionable items that we strongly are advocating for is that for the 92% of all Canadian seniors that live in the community, to make sure that provinces are covering high-dose flu for them. And that it's not just high-dose flu, but it's also for viral pneumonia and also for Shingrix, the new shingles vaccines. Now, these have been covered in Ontario and to some degree in Quebec, but BC has the worst vaccination rates in the country and the highest degree of vaccine hesitancy. So this is an area that we can really make positive response to. We have some other ideas about how we can make sure that we have a vaccine adult schedule like we do for children, and make sure that there's a focused response for infection prevention, and particularly in congregate and long-term care settings. For those of you who are close to large tides, and I certainly lived in Steveston, BC, and I would always keep a weather eye out for that big wave or that earthquake. One of the other things that we don't have in Canada is a disaster response for seniors. It's easily put together, but it has not been a priority. And it's one that for the area surrounding the North Islands and so on, a disaster response for seniors needs not to be the goodwill of a neighbor next door, but a coordinated effort by the Public Health Agency of Canada, connected with organizations like the Red Cross, to make sure that older people are not left behind, left alone, affected by heat, frozen from cold, or left in the concerns of other forms of disaster. I know that my friend Isobel is going to focus, as she should, on her wonderful report about caregiving, long-term care, and the health and housing resources, particularly on her most recent report. But you've done a lot of work on this whole health and housing continuum. And I just love to open up when we're having our Q&A to talk more about this. But you can see that family caregivers, and by family, I do mean the broadest possible terms, supporters, people who care, built family, community supports of essential caregivers are a critically important point. And Isobel's report will speak more to the measurable differences and impacts by not having caregivers, but we need to help them as well. We know that we need more and better staffing. We know that BC did better than other jurisdictions by acting more quickly with immediate responses than, say, in Ontario and Quebec, where the increase of death and morbidity was 10 times. But still, we have a lot to learn. We need to understand about how to age in place and to change the model of care from home care to care at home, and have the integrated care supports models that we know that we can do. We've got great examples of doing it in a pilot. We need to do it as an entrenched right of Canadians. Economic security is really important, and never before has it perhaps been so clear that older people are negatively affected by things like COVID-19. We saw that this government did a one-time funding of $600. And our question was, why do you think that they only need it one time when every other kind of cohort is showing that they do need ongoing supports? That same is true as well for people with disabilities who would qualify under that legislation. But there was this sort of disconnect by the idea that somehow day-to-day costs would be more easily borne for older people on fixed incomes, and that just wasn't the case. So here's a number of key issues. We were very pleased to see the tax filing for some seniors be included in the throne speech, which we know has been an area that the NPP has been talking about for many, many years. And we can talk more about reducing ageism and workforce inclusion. That particularly takes us to our last area that I just wanted to highlight for you in our roadmap to an age-inclusive Canada. You know, the UK has a minister for loneliness, and we have studies that say being lonely is as bad for your physical health and well-being as smoking 15 cigarettes a day, and increases your chance of morbidity by about taking 8 years off of your life. It's huge. We know that social inclusion is incredibly important, and we've got mapped some areas here: technology, transportation, ageism, above all, ageism. Really want to recognize the role of Indigenous seniors, and in that particular issue, it was Indigenous-led community that actually shared what they thought was most important. And also, we're looking to promote intergenerational wisdom, which we know has measurable supports and needs. So I'm hoping this roadmap will be helpful for you, for your communities, in your advocacy, in your work, in talking with your policymakers. There's lots of ways to stay connected with us. Some of them are here. We're also excited to offer free memberships, so you don't have to pay for anything. You can go to canage.ca/join. Our newsletters come out regularly. You see my email, and I'll share that again with the chat. What I'm hoping that we get out of kind of our conversation today is a sense that there is hope, there is a roadmap, we know how to do it, now we have a plan. Let's start divvying up who has what responsibility and making those positive steps forward. Thanks so much for the opportunity to talk to you today about our roadmap.
Well, thank you so much. I really appreciate that, Laura. And I recognize how much more I've learned about vaccines for seniors from our work together. So next, I want to acknowledge Isobel Mackenzie. She is amazing, and I've really appreciated working with her in her role. I have just respected her ability to reach out to communities and have meaningful conversations here in British Columbia. She has over 20 years experience working with seniors in home care, licensed care, community services, and volunteered services, led a nonprofit serving over 6,000 seniors annually, was once named BC CEO of the Year for not the nonprofit sector, was appointed as BC Seniors Advocate in 2014, the first such appointment in Canada, and has served that role since. She works tirelessly to bring voices and concerns of BC seniors to government and to the public, including just yesterday with the release of the results of a survey on the impact of visitor restrictions for long-term care facilities. I really respect her work. So grateful that you're here, and would love to hear what you have to say. Thank you so much.
Thank you very much, Rachel, and thank you for bringing this group together. And as always, it's a pleasure to hear Laura. It's not such a pleasure to follow Laura, but I will try to hold your attention as rapidly as she is able to hold people's attention. And I was reflecting back, Rachel, a few years ago when I came to visit you in your constituency office up in Campbell River, and how many miles that you've tread since then, and as have I, and the work that you do for the North Island, in addition to your role as when you were in the seniors portfolio and as you've taken on new ones. So I really do appreciate your bringing this group together. It's very important for me to remain grounded, meeting with people from throughout British Columbia, and my wings have been clipped a little during the COVID travel restrictions. So I am very grateful for these opportunities to meet with people in the community. And I see actually a few familiar faces around the gallery view here. So I'm just going to talk about a few things. Rachel, you've sent some questions or some things to talk about, and then I'll lead into the report that we released today. So one of the issues to talk about is just affordability and some of the questions around what is the role of the federal government in terms of income supports for seniors. And one of the things that I think is underappreciated is the degree to which affordability is an issue for many seniors. Part of it is that the poverty, for want of a better word, amongst the older population is more hidden than it is amongst the younger population, in part because people sort of muddle through and muddle along, and they're not as necessarily as visible as some of the younger population who also, many of whom also face affordability issues. But to put it in perspective, about 33% of British Columbians are on the Guaranteed Income Supplement, the GIS. And if you're on the GIS, for the most part, you have an annual income that's less than a full-time job at minimum wage. So that is a bit of a sobering thought of people who are trying to get along. Now, the other challenge is, okay, we could increase the GIS, we could increase the OAS, for example, but what that doesn't really address is the gap that I see exists for people regarding their health status. So if you are on $25,000 a year and you're 75 years old and you live in a $800 a month apartment and you get your SAFER grant and you're healthy, your life looks maybe marginally okay. But it looks very different if you don't have good health, actually, because there are a number of supports that become health supports when we're older that aren't health supports when we're younger. And the challenge for the federal government is, how are you going to support funding the services versus if it is simply an increase in income across the board, how are you closing that equity gap for the people who don't have good health? And For BC, one of the issues, and I have identified this now to 2 different governments, and I've met with Health Canada to see if the federal government wants to take an interest in this, and that's the charge we have for home support services in BC that they don't have in most provinces. They don't have it in Alberta, they don't have it in Ontario. They have versions of it in some of the other provinces, but it's by no means as usurious as it is here. And people on the GIS are exempt from that copayment, that's true. But if you're just over that threshold, your daily rate is quite high. And so I've been talking to the federal government about this is supposed to be an entitlement, and how are you squaring that with the fact it's people are paying for it? That's going to be some food for thought for the folks down at Health Canada. And the other issue is the housing costs. So I presented to one of the parliamentary committees, I think, Rachel, you were on that committee, and contrasted, I think it was Charlottetown to Vancouver, of 2 women with similar incomes. And the big difference was what they paid in rent. Because again, when you are on $30,000 a year and your rent's $800 a month for a nice 1-bedroom in certain parts of the country, versus in the west end of Vancouver, where you're having to spend $1,800 a month on your rent, life looks very different. And so how are we squaring that? One of the challenges is that federal governments of all stripes, although there's been one stripe I guess we haven't seen yet as the federal government, have tended to do these grand gestures of funding the provinces to build the buildings, right? And they're usually matched and all that kind of thing, which doesn't really get at the heart of the issue, which is how are we going to help these 20% of seniors in BC are renters, and they really do need some help. And our SAFER program is good. We've seen some increases to it, but it is still inadequate in many of our urban centers here in BC. So those are some of the challenges around how do we have the policy. Laura mentioned the $300. Everybody got $300 additional OAS and $200 more if you were on GIS, and everybody got it. So I can't think of a public policy person out there who wasn't shaking their head going, you've got to be kidding. Why are we giving, by giving to everybody, if you're going to have, pick a number, if you're going to give away $500 million to seniors, let's target it. Let's not make this a grand gesture that looks like we really, first of all, it was topsy-turvy. The GIS should have been higher than the OAS because the GIS is going to those with lower incomes. We didn't do that. We could have given more with the same amount of money by simply, if you were above the cutoff for OAS, you don't get it, or even make it taxable. Because the fact is, when you don't have much income, you don't pay much tax. So having it tax-free was actually of very little benefit to the people who really needed the money. It was, however, of the biggest benefit to the people who didn't need it because they pay high taxes. So, these are some of the sort of the subtleties of what we look at. And I certainly am very committed that, and Rachel knows this, she's, at the end of the day, there is a finite pot of money. And the job of government is to reallocate that pot, or to allocate that pot of money. And I do think that we need to be targeting to where the support is needed the most. And that is how we are going to bring up the floor, if you will, rather than just spreading it out equally across, whether people need it or not. And so these are some of the things. I think the increase to the OAS for people over 75. First of all, OAS is taxable, and there's the clawback at the, I think it's at about 70-some thousand it starts. So there is a progressive aspect to that, so that's a good thing. People have asked why not at 65, why wait till 75? I suspect that had to do, that's a financial calculation and also based on looking at incomes between 65 and 75. If they were to give an extra boost to GIS, that would help the GIS between 65 and 75 to bridge. That would be a thoughtful policy way, I think, of making sure that that group from 65 to 75 who really do need that extra OAS are getting it. Not through the OAS necessarily, but just have a bridging benefit, for want of a better term, in the GIS from 65 to 75, at which point the extra OAS will kick in. I've been asked about pharmacare, and there's a lot of talk about a national pharmacare program. In BC, we won't really notice a difference from a national pharmacare program because we basically have the equivalent of that in British Columbia. We're the only province that provides coverage for everybody. What we might see is that formulary, the drugs that are covered might increase because there would be a national formulary. That's possible. I predict that they're looking at the British Columbia model as they look at a national model. And I think we have to understand that there's no pharmacare program nationally or provincially anywhere in the world that is going to provide any drug you want totally free of charge, regardless of your income. Nobody gets that. It's going to be a combination of reference-based pricing, so the list of drugs that are going to qualify, and tied to people's incomes. So people who are able to contribute more to their drug costs will be expected to do that. And that's going to allow for wider, more comprehensive drug coverage for those who can't afford to meet their drug costs. We find that where the challenges lie for BC seniors is mostly around when a drug is not on the formulary. So it is about this drug isn't covered. Part of my frustration is we do have a special authority process in BC, and I think 75% of those are approved. The physician has to write for the special authority, and the problem is that we have not built into the fee code for the physician to get paid to write the paperwork to get the special authority. So there's a place where I think we could do some remedy. When you talk about vaccines, for example, Laura's right. We don't cover some of the vaccines we should. I've certainly been talking to public health about that. One of the challenges is the NACI recommendation. So that's the fallback that our government will say, we follow the NACI recommendations, and they need to be stronger on the high-dose flu vaccine than they are. And I think that the shingles vaccine actually is on the list. I think the only reason it isn't funded yet is because it isn't approved. But we make it an all or nothing game. So we haven't funded it as a vaccine, which would make it completely free of charge. We also don't have it on the formulary. So, an intermediate step would be to say, allow these vaccines to be on the formulary so that those who have challenges paying for them will be covered under pharmacare. And those who can afford to pay for it will pay for it. That is what pharmacare sort of balances out, right? It's as a basic drug coverage program. I don't know. I'm hopeful we'll get it would be better if they were provided to everybody free of charge, but short of that we would be able to make sure that people could get them. It's not an economic impediment, and we would achieve that if we put them under pharmacare. And then I'm going to talk about long-term care, and particularly the report that some of you may have been made aware of that my office issued yesterday about the visit restrictions in long-term care, which is really part of a bigger conversation about long-term care. And the bigger conversation is about the involvement of family members in long-term care and having a system that respects the voice and the contribution of family members, because that's the underpinning of the issue that we have. So I noticed some people on the Zoom call who will be very familiar with the role that resident and family councils and family members can play in both detecting issues in long-term care, bringing those issues to the attention of the people who oversee long-term care and making steps toward having those issues resolved. The challenge is we're not doing it systematically. And when we look at these visit restrictions, what we found was that it's been 9 months now, we're going into our 9th month since visit restrictions were imposed. And we had a period of time when we had essential visitors only. And what we found was most family members didn't know about that actually. And those that did know about it and who applied for essential visits, almost half of them had those requests refused. So you had probably, we estimate about 80 to 85% of our residents in long-term care went for 4 months without a family visitor. That only about 15 to 20% actually had essential visits during that period of time. And then when the visits opened up on the beginning of July, they were restricted to one designated visitor, but there was a sense from family members that now they would be able to engage meaningfully with their loved one. And what the survey found was that as it was entering the 3rd month since the relaxation of visit restrictions, which is when people were answering the survey, that half of people were visiting, only allowed to visit for 30 minutes or less once a week or less. And 30% of the visits are outdoors only. 20% have plexiglass between the people visiting, and only 20% of the visits are happening in the resident's room. And that's significant when you compare to what people were visiting prior to the pandemic. So if you were somebody who only visited your mom once a month because she lives on the island and you live in Vancouver, you haven't noticed a big difference, actually. You can still do that. And if you're the daughter in Toronto who flew out once a year to visit mom, you haven't really noticed a difference yet. But if you were that daughter or that wife who went in every day or several times a week and spent several hours with your loved one performing a variety of essential tasks, and that was about that's the picture for about half the people that answered the survey, and over 13,000 answered the survey. You've noticed this is a profound difference, and it's been 9 months. And then I think for me, one of the most clarifying points to make when we talk about the balance and the safety and the dangers of COVID is to recognize that in these 9 months, while 151 people have died tragically from COVID-19 in our long-term care assisted living, over 4,500 have died from something else. And they didn't see their family or spend any time with them of any amount in the months, weeks, and days before they died. We asked survey respondents who had a loved one who was either currently palliative or who had passed away during the COVID restrictions about their experience. And half of them more than half did not get to spend the amount of time they wanted to with the one they loved. And just over half of residents were restricted to one visitor. And in actually 9% of that was no visitors before they died. And so you have to step back and say, what's the purpose here? We've sort of lost the plot a bit. We have gone to a lot of fuss and feathers around these visits, and they've got to be organized, and they're in common areas, and we've forgotten to step back and remember what we've learned about how this virus transmits. I've run a care home. I know droplet precautions. This is a droplet precaution. When a resident, if they put on a mask and they've washed their hands, they can actually touch the resident because the virus isn't transmitted that way. It's droplet transmission. They can go to the resident's room. They can, now taking the mask off, that's complicated. We have clear masks now. It's just astounding what industry has responded to, so people can see lips move, and you can't kiss your mom, that's true. that is a significant risk increase. But you can touch, you can be in the room. None of that is going to increase the risk by any measurable amount, particularly given that people are already, those are the visitors that are already visiting. Increasing the visits and allowing just even one more person in, it mathematically increases the risk. But floodgates aren't going to open here. I'd like to think they would. There's not going to be a lineup of people to get into the care home. There are a lot of people who won't have any more than one visitor. And sadly, some will have no visitors. We can let one more person in. If you've got a mom and a daughter out there, mom's been going in to see her husband as the designated visitor. The daughter hasn't seen her dad in 9 months. Or two sisters who used to spell each other off. I'll go to mom on Tuesday, you go on to see mom on Wednesday. One of them hasn't seen mom for 9 months. And so even though we've got a lot of cases happening. I just saw the new numbers for today. I think it's 335, 200 plus in Fraser. Yes, that is true. But, and I expect we have some new outbreaks. But we've got to ask ourselves, what are we doing this for? Quality of life is important. Residents said, residents in long-term care, only 4% of them are very worried about COVID. The vast majority are only somewhat worried or not even worried at all about COVID. When we get to the end of our lives, we know it's quality of life that matters. And those letters that came from these, thousands of comments and letters that came with these surveys of people who are afraid of dying. They're not afraid of dying of COVID. They want to see their family. They don't have years left. They know that. We know that. And they want to spend the time with the one they love. We know how to make it safe. We can't get the risk to zero, but the risk in long-term care is not zero. We're not preventing their death. They're dying. 4,500 plus. They're just dying without having the ability in the last 9 months to have seen their daughter or to have spent any meaningful time with their wife. Someone they slept 6 inches from for 60 years, they're now being kept 6 feet from. And it's been 9 months. So I think, it is not without risk. So, there are people who responded to the survey that supported the restrictions, and there's been a lot of support into my office from the report, but there are people who do not, how could you possibly be so irresponsible as to open up visits during this time? But they aren't the people in long-term care. So that weaves back to who's speaking for these people. And one of the things that was a gap before COVID, COVID, like many things, has just revealed why it's a gap we need to close, is no voice for residents and families at a provincial level. And so I've asked the government to work with my office to have a provincial association of resident and family councils in BC. This isn't rocket science. When the government needed to consult during this pandemic, it quickly gathered together. You know how it works, Rachel. You get the stakeholders. Who are the stakeholders? They're not individual people. You go to the list. You've got, the BC care providers. Okay, well, let's get them in here. They're the care homes. Denominational health. Okay, let's get them in here. The HEU. Okay, let's get them in here. Safe Care BC. Okay, who's around the table? Okay, so you've got the employees are represented, the operators are represented. There's nobody there for the residents and nobody there for the family members. And every single decision about this has been made that way. And that's because there's nobody for them to go to. Every care home has or most, not every, a resident and family council, but they are operating to varying degrees of capacity. And there's no formal way to knit them together. We have actually the Vancouver Island has got we got the Vancouver Island sort of network or consortium of resident family councils Kim Slater had set up. There's a sort of a genesis there, but it needs that more comprehensive organization. It needs someone like Laura to get out there and bang the drum and be at the table. It's not a lot of money. It's going to be very inconvenient for people at times. It's very, it is a lot easier to run the care home, but don't forget I've run them. It is a lot easier to just run them the way you think they should be run.
Mm-hmm. I agree.
Right? It is the inconvenience of having to listen, you know, and the eye rolling and the telling to the daughter, no, your mother had a bath last week. She just doesn't remember. No, your mother doesn't. I've been there. I believe I've had those conversations. Right? But we need to do that. We need to listen. You know, we have in healthcare a culture we've created, no decision about me without me. And we have the Patient Voices Network, and we're all running around and we're all embedding this in everything. Not in long-term care. Not in long-term care. There are a lot of questions for the lawyers to be asking about the incredible suspension of civil liberties in the past 9 months, many of which people are on board with. But this is a disenfranchised group that I do not think, when we look back, history is going to judge us kindly on this. I really don't.
Yeah, I would agree with you. I mean, you can see in the chat, I mean, my analysis is that it's a fundamental denial of both charter rights as well as an illegal restriction. I am talking with people who are trying to get habeas corpus, which is what you try to get when you're in prison, to get out of prison. If we're in a position that people are trying to get out of restrictions and restraints that are not, I mean, not that we should be doing it to prisoners either, but we actually don't have solitary confinement anymore in prison. And yet we're in fact keeping people locked in their individual rooms, many of which don't have air conditioning, you know, for all of these months on end. I mean, I think that there will be very serious questions asked. It's been my personal opinion that it has been an illegal detention. And so there will be, I think, a reckoning around that. And one visitor was a very minute number, certainly much lower than other provinces who are putting things in. So I think BC did some things well and then some things very poorly. And this is one of the things they did quite poorly.
But the challenge, Laura, and to the people listening is, we did this because we care. We didn't do this because we were bad people. And, you know, this government, they have poured tremendous resources in. There was very quick, very swift action on long-term care at the beginning of this pandemic. The government has poured money into this. I cannot fault them for that. Mm-hmm. This is a more fundamental issue around our paternalism toward older adults in general, seniors in general. And paternalism is a very difficult issue to wrestle with, because at its core, it's because we care. We're doing this because we think it is the best thing for you. And that is how these things start. And so this is challenging. And I think, you know, I was blown away by the number of people that responded to this survey in a very short period of time, and the stories and the accuracy. I mean, the other thing that I was astounded by in the survey, because I'm a bit of a research purist about a lot of things, and this was like online, you know, how am I going to control this? How am I going to, but there were a number of there's checks and balances in the questions, right? If you say this over here, then you should be saying this over there. They were all there. And the people who answered this survey, you know, it's not like there was such utter reasonableness in these answers that you knew they were accurate, right? So everybody isn't saying that their loved one met the criteria for essential visits. Everyone isn't saying, oh, I went every day or all the time. Everyone isn't saying, these were thoughtful, honest, accurate answers by a group of highly committed and engaged family members. and we need to listen to them. And we
Well,
need to do that. We need an environment. Sorry, and
no,
I'll
that's
wrap up.
okay, Isabel.
Over to you.
I want to just recognize for people that some people are going to have to leave in a few minutes, and I'm sure Laura's already
I'll wrap
said
it up.
she can stay a little bit longer, and Isabel, if you don't mind staying a little
Yeah.
bit longer. You know, for me, and you, both of you have heard me talk about this, one of the challenges that I think we have is there is no strategy, there is no plan. And you know, for years I've been fighting the federal government to bring groups together, to bring seniors together and look at a national strategy, because we do have this growing aging population, but we don't really have a plan. And when I talk to so many different groups, I can see where if we worked collaboratively, if we shared best practices across Canada, because so much of seniors' care and services and supports are really done provincially or territorial. And so then we have one place doing something great, but other parts of the country not even knowing that it's happening. And, you know, I listen to so many people, and, you know, most of you all know that I have a mother who is in Campbell River who is at a care facility. And I have not hugged my mother since the start of COVID. I've gone to see her, we've walked together, I've cleaned her hands so I could at least touch her a little bit. But it's been so hard for loved ones because the regular things they used to do all the time, and of course I'm one of those daughters that's often not home, so I don't see her as much. But there is no plan or strategy moving forward around these very important things. And I couldn't agree more. You know, often seniors are not included, and they are vital. They're energetic depending on where they are in their own personal life. They have the time in some cases, but the lack of consultation and often lack of consultation with seniors who are having fragile health, who are from the communities that are living with disabilities, from the low income. I couldn't agree more. You know, I had some seniors saying I didn't need that money. Why did they send it to me? And other seniors saying, if I had $300 extra a month, it would really help with the dispensing fees we're now having to pay, you know, having to pay for groceries to be delivered, all of these added expenses that are specifically around COVID. So I'm just going to leave it to the two of you to just answer maybe that question is, how can we move forward to have more of a coordinated approach, and what kind of strategy do we need so that we can include seniors, but also make sure that our plan meets the needs of the people in our country?
Great question. This is why we actually put pen to paper and did all of the work, was to create the bones of a senior strategy, which integrates health, wellness, social inclusion, recognizes abuse, looks at what we need to do in terms of keeping people healthy and well, and understanding that older people come in all shapes and sizes, and that some are frail and some are not, and some were not frail yesterday but slipped and fell on their front porch and are frail today, and some, you know, will have cognitive impairment because they've lived a long time, and some will never have cognitive impairment. The reality is we know how to create a senior strategy, and so our hope at CanAge is that the roadmap that we have been created with just a few modifications, and Rachel, happy to talk to you about how to just do that couple of modifications, is actually a roadmap. It is actually a senior strategy and connects all of those pieces together. So we can do it, and here is the document. We hope that we can work together to just do that final twist to make it into our senior strategy.
And I think, you know, Laura's proposal, or that she presented, yeah, it is a very good, presents a very good architecture for a plan. And whether, Rachel, your role as an MP is to, how do you get that to either the provincial territorial table on seniors, the national, advisory council on seniors. There's something that Deb Schultz is putting together. I mean, how do we elevate this up? Because I think there has to be, the federal government has to champion this in some way, and bring with them each province, because we can't change the basic Section 95, division of, I think it's Section 95, can't remember from first year, division of powers between what's a provincial responsibility and what's a federal responsibility, right? I mean, we have to work with that. You have to engage the provinces. They each want to do their own thing. Everybody's more special than the next person, right? I mean, as I've often said, being the best of a bad lot is not the goal. But yet, well, you go in, well, what are they doing? Well, we're better than them. Well, we're stop it, right? We've got to come to the table. And I do think, Rachel, that there is a role for the federal government to play, even within the complexity of our federated country, around setting some standards. I really do. And they sort of have dipped their toe in and pulled it out, I suspect, because they get pushback from the provinces. But the federal government is the federal government, right? It has a responsibility to lead. At the end of the day, you can attach strings to the money. So you can say, we can't do this. That's very true. Okay, we're not going to change the Constitution, but we can attach strings to the money. And that, I think, is, they could use, they have the tool to more equalize things. And you've got to balance it with the inequities across the country. Housing costs are different, labor costs are different, et cetera. They're smart people, they can figure all that out. It's how, from my perspective, and my responsibility is BC, not Canada, but but we all pay our taxes to the federal government, right? Is that there should be, there's room for more standardization. And we've got to, in my opinion, and I said this publicly, and not everybody agrees, because some people liked the $300 they didn't need, but we've got to raise that floor, right?
Well, and I agree, and I appreciate what you're saying about standardization, because I know, and a couple of people have asked this, and we got this similar emails and questions from constituents, is around the reality that we saw in long-term care facilities across Canada, and this desire to see more national standards. And so some of the questions that I've got, and it's something the NDP, of course, has been advocating for, and I'm hoping nobody will disagree with us terribly today, but just around, can we do something, can we add those standards within the Canada Health Act so that we actually have something measurable that's consistent from one part of the country to the other? What are your thoughts on that?
Yeah, I think it's going to be hard, and I think you'll end up in a constitutional crisis that will make Meech like a cord look like a cup of tea. So no, I mean, the lawyer in me says I really think that would be very difficult. In
Laura!
Sorry, when 1987, when we designed the Canada Health Act, the average age of death was 76.4 years old. And so people say, why didn't we have long-term care? And it's because we didn't live long in 1987. So we've had this longevity dividend that is a success, but we never planned long-term care, which is why we have this kind of slightly come as catch can analysis across the country. Having said that, there's a question that Tara asked as well, and I put in the chat a great report by Dr. Pat Armstrong that maybe many of you will know, Canadian Centre for Policy Alternatives. The link is in the chat. We can circulate that to you as later. Pat's response was to create a parallel, not the Canada Health Act, because I think the government would fall before that actually worked, but a parallel piece of legislation that looks at that. I think that is actually a possible thing. What I think we can do most quickly, just building on your point, Rachel, here, and this is certainly one of the pieces that our roadmap for Canada's Seniors, the Voices document I shared with you before, talks about that national quality standards. We've been advocating for it very strongly, and we did a little cheer when we saw it in the throne speech. And that tethering of money to quality standards, I encourage people to have a look at the Australian model. That is very similar, the same division of powers and a mix of for-profit and not-for-profit. I'm not saying that's the good or bad. I'm just saying that that's similar to what we have right now. And yet they have a very strong regulator who can actually suspend licenses and issue fines of up to $100,000 a day, not an incident, a day. And they have had when I say a handful, I mean like deaths on one hand from COVID-19 in long-term care. And that national regulator has also required things like changes to infrastructure, a single or a spousal partner room with an ensuite bath, with also, air conditioning and so on. So many of the things that we know that we need to do, plus an integrated requirement of staffing, not downloading everything to CareAids, but having the right mix of care. So Yes, physiatry and people taking care of your feet and podiatry and rehabilitation. And actually, the odd doctor would be nice in long-term care because they're pretty much like chicken's teeth right now. So instead of downloading it to often racialized women who stay in long-term care for about 18 months before they rotate out on average in Canada, let's make it a profession that we can have dignity and respect. And I do have to say, BC's done better in that than other provinces. And if we're still complaining about BC, it does mean we've got a long way to go when the rest of the country is worse. So the recipe is there. Canada Health Act will be hard. Separate federal legislation would be more possible. National quality care standards is what we can do right now.
Well,
Yeah.
I'll fight for that, Isobel.
Yeah, sorry, Rachel. I agree with Laura on the CHA, right? It is, and my worry is it would become a distraction, right? So we'd be so focused on trying to do that, that could tie people in knots for years, and that would work for some people to just push this down the road. So I do agree, actually. I mean, if we needed to go down a legislative path, that separate legislation might be the way to go. But I do think this issue around quality. So the other discussion that I worry about becoming a distraction is this discussion about getting rid of for-profit and all of it, because that is something that the simple mechanics of doing it are unbelievably incredible, and it would take a very, very long time, cost a tremendous amount. It would become a distraction. What is missing is the accountability and the incentivization. So if it's not, from what I see, it's not that they are a for-profit operator per se, it's that the way we fund them does not incentivize that operator to deliver the services that are in the public interest with public money. And if we did that, I think what would happen over time is we'd get to a higher percentage of not-for-profit and public ownership, because it would become less lucrative and attractive for the private market, right? They will exit. So we won't have to do this big appropriation and this big, it will happen naturally, because what we are going to say to operators is not, here's your envelope of money, go and spend. We are going to say, spend this on this, spend this on this, spend this on this, because we have targeted where we want the outcomes that we want to have. That is absolutely achievable very quickly. And one of the places where I think we would start to see improvements immediately is not just around, you must spend this money on hiring care staff, you must pay the care staff this amount of money. We don't have to set a because as we do that over time, a lot of problems are going to be not solved, but they're going to be reduced. So the wages will rise. There's no, supply and demand. We have a labor shortage. Well, when you have a shortage of of supply, price rises, right, relative to demand. So that is true of wages as well. So if we say, this is what you must, we will start to see that happen over time. And then the other thing, I did study a model in the UK where they have a national quality council. It's actually a legislative federal, UK-wide body that actually reports to, I believe, the House of Commons. I believe it isn't to the government. I believe it's to the House of Commons. And the long story short is, they do what Laura's describing, they do. And so if I'm a care home operator, I have this body that's not tied to what my funding is, and they're coming in and they're assessing and they're doing these things and they're giving me quote unquote a rating, and that's driving everything. And one of the challenges, because incentives matter and regulatory capture matters as well, which is something we don't talk about a lot. And one of the challenges in BC is a tremendous amount of regulatory capture, because we have, when I'm going in and inspecting the care home, I am actually, and as the health authority, even though I'm supposed to be the regulator, I see my job as making as aligning with the objectives of the operator. It happens over time. People mean well. They've got all, but it happened. We've got to acknowledge what
Isabel,
happens.
I'm sorry to interrupt you, but somebody's asking, what does regulatory capture mean?
Very good. Regulatory capture is an economic term, a Nobel Prize winning economic work of Stigler. And basically it talks about we become captured by the industries we are trying to regulate over time, because we start to identify with them. It's one of the reasons why you should be changing your auditors every 4 years or 5 years, right? Because the auditors start to become embedded. It's a very, I could obviously go on as you're becoming aware of. And the other famous example of this is Eisenhower's big industrial complexes, where he said basically, this was in relationship to the wars, be very careful about the industries that are going to benefit from you going to war as a country, advising you to go to war, right? That was basically, it's a very simplified version of what Eisenhower said. What we have in Canada is, we have the industry telling us what we should do. That is what we have.
Mm-hmm.
And we have to admit that, Rachel. We see it, we gather the people and we listen to the people who, by the way, are going to build the new beds, are going to operate the new beds. They're the ones we're listening to tell us how it should be. And we've got to step away from that. Yeah. And it's a very hard thing. It's a very hard conversation to have, because nobody thinks they're influenced. We all are influenced, right? And this survey with these voices is that we just did is an absolute example. We are listening to what the operators say, and we're listening to what the staff are saying. We aren't listening to what the residents and the family members are saying. Mm-hmm. These are difficult conversations to have.
Well, and I think, what I've heard from actually nurses and healthcare providers who've come to my office and said, there are so many challenges. Accountability is a challenge. We're trying to fight this fight, but people think we have too much in the game. But the reality is, the people who we're serving, the loved ones of the families, by the time they get to the end of their journey with long-term care and their loved one is gone, they're exhausted and they don't have the energy to fight. So we're trying to fight because they're exhausted to fight. How do we get them to fight? And I think, accountability is key, and making sure that people are safe and cared for, and that it's not just completely exhausting and breaking the hearts of the loved ones who are trying so hard.
Yep.
Yeah. So, oh, sorry, go ahead, Laura. And then I'm going to ask the last question and wrap up, because I do want everybody to
be able to know. So that is why we need residents and family councils. They're separate entities too, right? They're not the same, because the voice of residents is not the voice of families. They need to be separate. And again, I'm using family in the most inclusive word. I just want to share with you that one good way of doing it is actually looking at how it's done in Ontario. And what's important is there's a requirement and a very specific set of lists that administrations must do to support residence councils and family councils that doesn't leave them any choice. And the other magic piece there is this, that the Ministry of Health and Long-Term Care must fund provincial entities for an association of residence councils and an association for family councils. That's the piece that's missing, because unless you've got something that's continuously advancing the rights and well-being of residents and families, it doesn't keep sustainability. So it's totally actionable, and we were cheering when Isobel's report came out with that recommendation.
Yeah, no, it's so important. And I think, the sad thing about COVID is it's really revealed all of the things that we knew were there, but in such a more profound way. And people who did not know I feel like they now know, and we have to all face that reality and start stepping forward in this new world. So my last question is just really on affordability and economic justice for seniors. We know that there are some seniors that are comfortably off, and they contact my office and say, Rachel, why are you fighting for seniors to get more? But we also know that there are so many seniors that are falling behind. And you both are aware that in last Parliament, I just haven't had a chance to table this private member's bill again, that I actually tabled a bill around guaranteed income supplement, because we learned that every July, over 30,000 seniors across Canada were getting kicked off guaranteed income supplement because they got their taxes in late. In some cases, 2 weeks late. And we just knew that that was not right. And so when we talked to groups, what we put forward was the idea that all seniors who receive guaranteed income supplement get a year's grace period, so that if something happens in their life and it's a little bit late, no big deal. And that there would also be an active strategy. And the people who were working in the dementia field called me about this, said make sure that CRA is repeatedly asking why, so that it will alert somebody in their world that they may have not sent something. So we put forward that, and I never forget sitting in the former Minister of Seniors office talking her through this, and her saying, is it really true that over 30,000 seniors are knocked off? And I'm like, here's the statistics that are from your government. Yes, it's true. Every year this is happening. And the poorest, I mean, when you have an 86, and I've had this, an 86-year-old woman called me crying, I'm going to be evicted. I mean, we helped her get her money quicker. We called the landlord and explained the situation. We kept her in her house. But this is such a big barrier. So just around economic justice, I personally think the GIS should be increased substantially. I think we should not be having seniors living in abject poverty. I think we need a lot more seniors housing that is not long-term care, but just affordable housing for seniors. You know, in Campbell River, we just had a housing group open up, and they had over 100 applicants, and about, I think 70% of them were seniors. And they had no idea. The people said, I didn't know it was that many seniors. It is. It's a lot of seniors that are even hiding their homelessness. So I'm just wondering if we could close the evening off just talking about how do we sort of create this environment of economic justice.
So first of all, CanAge supports absolutely everything that you have said, Rachel. Without question, we strongly support that bill. We want to move forward and support that again. The torches of what you're saying are speaking to the heart of our advocacy priorities. So all of this is yes. Yes to affordable housing. Yes to supporting care at home, not home care, because people, about 20% of the population, I'll give you the Canadian population, Isobel can give you the British Columbia one, could be actually back at home if they had adequate integrated supports and cares. Whether they're helping naturally occurring retirement communities where groups of people are getting services at a bulk rate because the communities are coming together to do it, whether we're looking at co-housing or home share type programs where often graduate students or younger people are living in home for affordable housing share costs in exchange for maybe 5 to 7 hours of, shoveling the snow or raking the leaves or walking the dogs. These types of programs make big difference in keeping people in community and older people integrated in communities as well. So it's that piece about housing and affordability, but also social inclusion. I'm also a fan at the municipal level, and I'm a little bit unabashed about this, that when new housing developments must come in, seniors and low-income integrated housing must be part of those priorities, and supporting the BC housing to advance those rights. And think about creative housing models, bring back co-ops, but make sure that they're flexible housing opportunities for seniors. We know the mix of exciting things that can happen, but it has been left to languish in my respectful view.
Yeah.
So I think, Rachel, from following much of what Laura said, I think that what we need to do is realize that the vast, vast, vast majority of Canadians are going to age and never see the inside of a care home. And in fact, one of the things we can do to help our care homes is to make sure that only the people that really need to be there are there, and they're there for health reasons and not economic reasons, right? So we do, because we do have people who are in long-term care for economic reasons in BC versus solely for their health reasons. They could be supported in the community. One of the pieces, so if we think of this as a continuum, and what are the practical pieces? So box number one are seniors who are renters. What is the appetite to administer some type of federal program around rent supplements? So that's box number one. Box number two is, and that's about 20% of seniors here in BC. I don't know what the national number is. Box number two are those seniors who are homeowners and but have low incomes. And one of the things that the Liberal Party talked about, I think maybe 4 elections ago now, was the idea of a federally administered program that would allow people to borrow against the equity in their house to fund some of their costs. That will be unpopular with some who will simply want the money, and why. But again, when we think about how are we going to reallocate these scarce resources, right? So we have people who, and some people will say, well, you just go and get a commercial mortgage, a reverse mortgage. That's problematic. I can tell you as a former case manager that by the time you need all that, we cannot send these people down to the commercial thing. We need to have them linked up to some kind of government program that's going to give them the cash flow they need in order to help stay at home. Those are the homeowners. Then overall, there's the issue around what are we going to provide to people free of charge? What is the sliding scale based on income around these things that are not health services when you're 55 and able-bodied, but they're health services when you're 95, right? So that's part of it. And then the big missing piece in the continuum from a national level is what is there between, my private individual home and long-term care. There's sort of that retirement home assisted living type of environment. And there is no uniform access for people to that to a subsidized form of that housing. Probably Alberta does it the best. Ontario is certainly one of the worst. There's no subsidized retirement home or assisted living. BC does it, we got a little bit. We need more, right? And we keep pushing people. We keep building we need more long-term care beds, We know from our assessments that there are people in long-term care who could be cared for either in their own home in the community or in assisted living. But it's cheaper for them to be in long-term care because that's subsidized. In Ontario, like if you're low income, you can shell out your $5,000 a month or $6,000 a month for your sunrise living place, or you can spend $3,000 a month for long-term care. And that is something I think the government needs to think about is on a national level, what are we going to say is this continuum? Most people never will end up in long-term care. And there are people in long-term care who do not need to be there. And some of them are there because economically that is all they can afford. But we are paying more for that than we would for some of these other supports. And again, the mountain is you got to work with the provinces. And what's the role of the federal? Because I think that's, the income inequality, it's really about in our senior years, particularly once we're past 80 and 85, it is about our inequality of expenses almost more than income, if you follow that logic, right? It's that I have to pay all these healthcare costs. Rachel doesn't, she's healthy. Mm-hmm. And yet we have the same income. That's the problem. We're actually working on a paper here, and everything. Nobody wants to hear about anything that isn't COVID. But one of the papers we've been working on is actually aimed at the federal government, and it's all about the sort of backwards way that we're giving tax relief for people around medical health expenses, et cetera, et cetera. First of all, a non-refundable tax credit means nothing to anybody on less than $30,000 a year. And even then, you know, when there's this, don't forget, most Canadians aren't 80. They don't know. So they have this notion, oh yeah, they can get a tax, oh that's a tax, you can get a tax write-off. Oh yeah, you get a tax. They don't understand materially that it's helpful, not for some, but it doesn't fundamentally make enough of a difference. And so we've got to figure out a better way of helping people who need to put a shower in their bathroom. You know, from my time in home care, it is amazing, Rachel, the little things that would drive people, mostly their kids, to saying, oh, got to go into the care home. Because, you know, it's going to cost $15,000 to renovate the bathroom. It's going to cost, you know, this much to do this. It's going to cost this much to do that. And yet if we looked more holistically, I think we could manage to keep people at home longer. And if we found a meaningful way to bring relief to the family caregivers at home, right? I think that would go a long way as well. And there may be more demand for this, because I think what has happened is a lot of people are thinking twice about long-term care. And I don't think they're thinking about it twice because I'm afraid of COVID. That's going to be gone. They're going to be afraid of it, number one, because of what they saw, you know, from this, you know, strapping young CF guys that go into a care home and what, you know, were outraged. Yeah, what did you think you were going to find? Say Laura and I. And also because of the separation. You know, one of the things in the survey, this is a terrifying experience in powerlessness that these families feel. Aside from everything else, right? Is this? It's quite gobsmacking to be told, no, you can't touch your husband. And we're the government, we tell you you can't do that. So that's got people thinking about all the things they're giving up when they go into a care home. And so it may give you more political, well, I don't know whether you would call it clout or capital or whatever, to pursue these issues.
Yeah. Well, thank you. It is getting close to 8:30. I've extended this by a whole half hour. This issue is so profound, it's so complex, and it's so important. And I think that's what we've left. I've asked a lot of questions that people sent to us and tried my best to watch the chat. Please don't hesitate to contact our office. We will do the best that we can to get you the answers that you are seeking, or at least connect you to the resources. Of course, you know that you have Laura, who is putting everything about CanAge in the chat there. And of course, Isobel, you can find her information easily as well. Please watch, please read the reports. Seniors matter, they're a strong voice, and I really appreciate how there's starting to be more organization around this. And I, you know, I'm hopeful that that will lead us, because I always say to people in my role, I work hard, I fight hard, but boy, when I have a bunch of letters or petitions from people, it just makes my voice stronger, because it's not just me talking, it's me talking on behalf of so many other folks. So I just want to thank you. And I just, in closing, want to say, you know, I had one of the elders come to me, and she said to me in this area, you know, if we were all following the traditional peoples of this land, the covers of our magazines would be elders, not young people, because we would be looking at the folks that had the most information, the most wisdom, and the most knowledge. And they are looked after. And I know in the community that I grew up in, the best thing that you could be asked to do was to go care for an elderly person, because it meant that somebody thought you were worth learning from that wise person. So I hope we continue, all of us, to strive to re-educate people and stop the treating poorly of people who deserve our respect for building our country. So thank you all. We'll continue to do all the work that we can. Thank you, Laura. Thank you, Isobel, for being here. I really appreciated all that you had to say. Thank you for the dedication and the time that you take to this. And thank you to my amazing staff who've had to stay half an hour longer. They're used to me by now. And thank all of you for coming. It really makes a difference. I could not believe how many people registered for this event and how many people said, please, I can't register. Can you send me a copy of it? And we will be doing this. It's on Facebook Live. And we will talk again soon. And if you want to do this again, let us know and we will do our best to organize it. So take care, everyone. Be well, and thank you.
Thank you.
Thanks, everyone.